Again, welcome everyone and good morning. My name is Kasey Petika. I'm glad you have joined us for today's session, which will focus on improving the recognition of pediatric abnormal vital signs. We're going to explore why the assessment and reassessment of pediatric vital signs is such a critical area for improvement within emergency departments, and why it's often overlooked despite abnormal vital signs being the earliest signal of pediatric deterioration. We'll also walk through the tools and strategies available through the National Pediatric Readiness Quality Initiative, or the NPRQI data platform, that supports EDs in measuring performance, identifying gaps, and making targeted improvements. By the end of today's session, you'll leave with both the rationale and the roadmap to begin improving the assessment and reassessment of pediatric vital signs in your ED. We would like to acknowledge that the Emergency Medical Services for Children and the Innovation and Improvement Center is funded through a cooperative agreement with the Health Resources and Services Administration, which is within the U.S. Department of Health and Human Services. Additionally, NPRQI is also supported by the Toyota Way Forward Fund. The contents of today's presentation are those of the authors and do not necessarily represent the official views of nor an endorsement by HRSA, HHS, or the U.S. government. A few quick housekeeping notes before we get started with today's presentation. Please know we want this to be a safe, supportive space. We encourage open dialogue, sharing successes and challenges, and asking questions. To keep us organized, please add your questions to the chat feature at any time, and we'll pause along the way and save some time at the end for questions. For those looking to receive continuing education credit, please add your first and last name if you haven't already to the chat, and complete the survey after the session. Now today we're joined by Robin Goodman, who has almost 30 years of nursing experience, 20 of which she was a Pediatric Emergency Care Coordinator, or PEC, in LA County, where she has had a passion for pediatric readiness throughout her career. But before we begin discussing the importance of vital sign assessment and abnormal vital sign reassessment, and the ways in which we can improve our performance in this area, let's first review the importance of pediatric readiness. Here is a surprising fact. 85% of children who need emergency care are treated in general emergency departments, not pediatric-specific facilities. That means most kids who come in with a serious injury or illness are seen in hospitals that primarily serve adults. So what does that mean? It means general EDs need to be prepared to care for children effectively. Here's the challenge. Many emergency departments see very few pediatric patients. When pediatric patient volumes are low, it's harder to prioritize pediatric-specific training, equipment, and systems, as staff may not encounter pediatric cases often enough to maintain confidence and skills. This creates a gap because when a critically ill child does arrive, the team needs to be ready. Improving pediatric readiness relies on understanding current gaps. This is where quality improvement comes in. Pediatric readiness means having the people, processes, resources in place to provide high quality care. The goal is simple. Every child should receive safe, timely, and effective care no matter where they show up. Because pediatric readiness isn't just a checklist, it's a commitment to quality care. And what we know is that quality improvement plans are a key driver in improving pediatric readiness. One of the foundations of quality improvement is that you can't improve what you don't measure. Quality improvement is systematic, continuous action that leads to measurable improvement in care. It's central to pediatric readiness and is associated with better outcomes for children. Yet, in the 2020 National Pediatric Readiness Project assessment, only 50% of EDs reported involving pediatrics in their quality improvement processes, and only 1/3 of those were tracking pediatric-specific metrics. That's a major opportunity for improvement. EDs who do include pediatrics in quality improvement efforts see a 25-point increase in their adjusted pediatric readiness score. And we know having a higher pediatric readiness score is linked to improved outcomes, with a potential 2,000 pediatric lives that could be saved annually. The National Pediatric Readiness Project assessment helps EDs identify gaps in their pediatric systems of care. You can measure your ED's pediatric readiness during the 2026 National Pediatric Readiness Project assessment, launching in March. NPRQI complements that by providing tools needed to address those gaps and monitor improvements using the 28 nationally recognized pediatric quality measures. that include the percentage of high acuity pediatric patients with vital signs reassessed. With that, I will hand things over to Robin to help lay the foundation of why we should improve the management of abnormal vital signs.
Thank you, Kasey. I'm so excited to see a turnout like this. This is amazing. So thank you all for joining. I'm very excited to be here and talk about vital signs, as well as pediatric readiness. So I wanted to start with walking through a scenario that probably feels very familiar to you. So you have a 5-year-old girl who comes in with fever and vomiting. Her triage vitals show she is a little tachycardic and tachypnic, but her oxygen sat is normal. Temp is 38.3. We don't get a blood pressure, and she doesn't look particularly sick. So she's triaged as an ESI 5 and sent to the waiting room queue for fast track. Think about that situation in your emergency department, that patient coming in. We see something like this all the time. So in situation A, or case A, a nurse rechecks her vitals about an hour later. Her heart rate has climbed to 165. Her blood pressure was taken and is noted to be 85/56 with a MAP of 66. Providers notified, she's moved to an ED bed, fluid and antibiotics are started, sepsis is recognized early, and she positively responds to interventions. In case B, vital signs are not rechecked. Patient waits over 4 hours in the waiting room. She begins to deteriorate. Her caregiver comes and lets the triage nurse know that the patient is now really not responding. And ultimately, she requires resuscitation, intubation, and an ICU admission. So this is the same child with the same initial presentation, but 2 very different outcomes. Difference wasn't technology, experience, or luck. It was one decision, whether vital signs should be reassessed on a patient. So during this presentation, I would really like you to think about how reliable, as we go through these slides and we talk about strategies, how reliable is your current process for checking and rechecking abnormal vital signs in children? So vital sign assessments, reassessments are one of the simplest and most powerful ways we can change the trajectory for kids like this. Next slide, Kasey. So full set of vital signs, why do we take them? And I always like to start off when I talk about vital signs is we have to get the vital signs first, right? So we need to get a full set of vital signs to establish baseline so we know where this child is at. Partial vital signs really limit obtaining that baseline. If you're just checking a heart rate or you're just checking a pulse ox, you're missing a lot of information about that patient. And that can really mask early warning signs, particularly in young children. So vital signs help us catch the physiological changes early, often before a child looks sick. And they help us identify risk and severity of illness or injury. And they should influence how urgently we act to provide care for a patient. So vital signs also guide decisions like triage, reassessment, escalation of care, and they should be a key critical factor in disposition as well. What additional important things they tell us is whether our interventions are working or if they're not. And ultimately, they help us get to the right resources to the right child at the right time. And I like to always put up here what are a full set of vital signs. And so what we're looking at here, Corey, Dr. Chibatazi last week talked about pain. And so we're not really going to focus on pain as a vital sign for this section, but we should be looking at, are we getting a temperature, a heart rate, respiratory rate, blood pressure, and pulse ox? And in some cases, pulse ox can be determined by policy on what patients you're getting a pulse ox, but those are the things we should be getting on all of our patients. There really are no caveats of patients under 5, under 3, under 2, under 1 that we should not be getting vital signs, because all kids have vital signs and all kids have the potential to deteriorate quickly. And we need to make sure we're assessing them just like we would all other patients. Next slide, Kasey. Right. So it's critical that we use standardized evidence-based ranges to reduce practice variability and support consistent reassessment and escalation decisions. And so when we're looking at vital signs, what resources, and you guys can put this in the chat, what resources are you using to standardize your pediatric vital signs? You guys can put that in the chat if you're using anything. It's important that we have standardization around this. PALS, yes. So love PALS, AHA, yes. So we're using standardized, and so that's EPIC highlights those vitals, EMPC. Okay, I love this. This is perfect. And so these are all really good. Badge cards provided by EMSC. Thank you. So these are all really important aspects that we've got to know what the ranges are, and we need to make sure that it's consistent across everyone. And so one thing about the badge buddies that's important is if you go between different facilities, oftentimes they may have different ranges. And so it's important that you understand what is the range for your facility, because not all of them use PALS. Sometimes they create their own. So we want to make sure we have these reference resources readily available. So can we embed them in EHRs? Do we have them in triage tools? Do we have vital signs cards? But we want to make sure that no one is trying to remember what a normal range is for a 1-year-old and also for a 7-year-old. Like, we should be able to use resources to help that. We shouldn't rely on our memory. So pediatric vital signs, again, change significantly with age and development. So we have to make sure we're using age-appropriate reference ranges for that. And then during reassessment, we want to make sure we have accurate age-based norms so we can trend and not just get that single data point on a patient. That trending piece is so important, especially when we're talking about children. Next slide. All right, so abnormal vital signs are often the earliest signal of pediatric deterioration. We said that a little bit earlier. And oftentimes the child will look really well before they look sick. And so because children can compensate so effectively, they may be talking and playing or sitting up while their physiology is already showing some stress. So small changes in heart rate, respiratory rate, blood pressure can often precede visible distress or decompensation in a child. So vital signs can give us that early warning, an opportunity to pause, reassess, and intervene before the child crashes. Early recognition also allows for timely escalation, appropriate resource use, and intervention when outcomes are better and care is less invasive. And that's the key. If we can see through our vital signs that this patient is in trouble somewhat, we can intervene quickly before we wait for that child to crash. Pediatric vital signs are not just numbers. They're often the child's first request for help. And that's something that has always stuck with me from when I first started as a nurse. That is what one of my preceptors told me. And I was at a primary children's hospital, but that was the key. She's like, the vital signs will tell you there's trouble. And so you need to make sure you're looking at those. So I just wanted to include here some data from Ram Gopal. This came out of, they had 162.7 million pediatric encounters. Of those encounters, only 51% of patients had complete vital signs. And of those vital signs, 73% were abnormal, especially in younger children. And those patients were associated with higher odds of hospitalization and transfer. They also found that elevated heart rate and respiratory rate were particularly predictive of hospitalization or transfer. So these findings reinforce why consistent and complete vital sign assessment and reassessment matter, because the children at highest risk may look well until they don't. All right, Kasey, I'll hand this back over to you.
Thank you, Robin. So now that we've looked at why the reassessment of abnormal vital signs is such a critical area for improvement within emergency departments, let's talk about how quality improvement operationalizes this improvement in this area and some of the tools that are available to you. One such tool is NPRQI, or the National Pediatric Readiness Quality Initiative. This is a free, self-paced quality improvement data platform designed for emergency departments. What it does is it helps EDs measure, benchmark, and improve their performance on key pediatric processes in a secure way. One of the biggest benefits is that it gives hospitals a clear framework for continuous quality improvement. That's essential for improving pediatric readiness and making sure kids get the best possible care. Ultimately, NPRQI is designed to inform and empower frontline staff so they have the insights and tools to make real improvement. NPRQI helps transform data into meaningful improvement using a simple structure of measure, reflect, and improve. You can easily capture data, track trends, and share your results with your team. Abnormal vital sign reassessment is one of these areas in which we can help drive change. As Robin shared, capturing initial vital signs provides an early warning, well before the child looks sick. Abnormal vital signs are key in the early identification of critically ill or injured patients. It is the early recognition that allows for timely escalation, appropriate resource use, and intervention. With variations in practice across EDs, standardized pediatric quality measures can help reduce risk. NPRQI is especially valuable when it comes to measuring the percentage of high acuity pediatric patients with vital signs reassessed, because it provides that standardized pediatric quality measure, offers you the ability to see real-time data for rapid tests of change, national benchmarking, and a place to track your interventions and see impact over time. Here's an example of the graphical view, which allows you to monitor trends, track progress, and even share this graph with your team and leadership. So let's put this into practice by walking through the process of reviewing baseline performance, setting an aim, and considering strategies for improvement. If you're just getting started with improving abnormal vital sign reassessment, we recommend reviewing 30 patient encounters to help establish your baseline performance. Having at least 3 data points will give you a more reliable average before you begin testing change. After you've entered your charts, you may find that your baseline performance is 50% of high acuity pediatric patients with their vital signs reassessed. When we start talking about improving any process, including abnormal vital sign reassessment, we need a clear target to work towards. That's where a SMART aim comes in. A SMART aim gives your team a shared, specific goal that's measurable and time-bound, so everyone understands exactly what you're trying to improve and how you'll know you've succeeded. SMART aims help teams stay focused, avoiding vague language or intentions like do better, and ensure that your changes you're able to test and are tied to an outcome that you can actually track. They also make it easier to communicate goals across your ED's team and monitor your progress over time. Using this simple template of by implementing an intervention, we will improve a process or practice, resulting in a measurable metric by a target date. Here's what a SMART aim might sound like when we put it into practice. By updating our triage posters with age-appropriate normal ranges, we will increase the percent of reassessment for pediatric patients with abnormal vital signs by 15% by June of 2026. Notice how it clearly states the intervention, the measure we want to improve, and the measurable outcome and the deadline. This level of clarity helps your team stay aligned and focused, and it gives you something concrete to track. Now that we've established a clear SMART aim, the next step is deciding how we're going to reach it. That's where a change strategy comes in. Change strategies are the intentional adjustments we make to our workflows, communication tools, or environment that help remove barriers and make that desired behavior, like consistent reassessment of abnormal vital signs, easier and more reliable for staff.
And thank you, Kasey. And so these strategies aren't random ideas. They're targeted actions informed by your baseline data, your SMART aim, and the real-world challenges your team experiences every day. So the goal is to choose small, practical changes that you can test quickly, learn from them, and refine them through PDSA cycles. In the next few slides, we'll walk through examples of change strategies that collaborative participants have used successfully to improve reassessment of abnormal vital signs in the ED. All right, so monitoring pediatric vital signs, one of the best ways I can also promote is chart audits. They're one of the most direct ways to assess whether key elements are completed. Were weights documented in kilos? Do you have a complete set of vital signs? I will include pain assessments here. Were they done timely? Were reassessments done? And were provider notifications done as well? Staff surveys, I'm a huge fan. People that know me well know I love a staff survey. I love an anonymous staff survey, I will say, because that's how you're going to get the best information. So sending it via email, I don't usually recommend. I get a piece of paper and actually just create a survey on like, where are you at with taking vital signs for kids, and get the information from your staff. Put a box out where people can just drop in their paper. And that's how, for me, that's how I got the best information from my staff around vital signs specifically. It's like, where are your barriers? How can we help? But it really gives you, helps you identify your gaps that you currently have, where people are struggling, and what you may need to do to support them a little bit better. Family feedback. How are we communicating vital signs with family? That goes a little bit into, patient satisfaction, but at the same time, it's, what families see on TV can be very stressful and scary to them. And so we need to be communicating with them around their around the assessment of vital signs, why we're doing it, and then communicating these are normal vital signs. Everything's great. The heart rate's a little high, but we need to be communicating that with our families as well. And so that's something that's important and comes up when we're following up with family about their visit or things like that. So we want to make sure that we're talking to families and explaining to them what's happening, just like we would with medications. Direct observation or workflow mapping, that for where I worked clinically for many years, that was something that we used, especially in our triage process, looking at the screener nurses coming in and the actual triage process, like that workflow and how we were incorporating vital signs into that. Are we missing equipment? Where are the barriers? Where are people struggling? Where they're saying, yeah, I'm not going to take vital signs on this kid because there were too many barriers for them to do that. And so we want to make sure that we have processes in place, because we all know nurses will create workarounds when we don't. And sometimes those can be more cumbersome than the actual just fixing the problem. So together, when we have these types of approaches, we can get a clear picture of where improvements are needed. Next slide.
And I think we have a question in the chat. I'll prorate to ask you now. It's what kind of stuff did you ask in your surveys of staff regarding those vital signs?
A lot of times it was just a how are you feeling about X, Y, and Z. So for vital signs, do you feel comfortable taking vital signs? And then I would do by age. I will tell you most people were the under 1 age group. People would get very nervous about that. So then my education plan would be, okay, so let's get some mannequins, let's get some kids. Sometimes we even bring in our own kids and say, okay, let's take vital signs on these patients. So let's make you feel comfortable in doing this and make you feel comfortable with the equipment. And so it's really, are you comfortable with the equipment? Are you comfortable with the patients? Are there certain groups that you are struggling with? Let's fix that for you. I also got some of the best just open text. I'd always have an open text where you can just write, where it's like, we can never find the neonatal cuffs, or we have to go X, Y, and Z. These are always missing in triage at the end of the day. So things like that, where it's like, okay, we just need to make sure we're stocking in this area, because we don't expect people to be walking across the department to be getting equipment for the patient. It should be readily available in your space, whether that's in the back of the ED, the front of, triage, in urgent, the fast track areas. You should have the resources you need to take care of those patients, wherever they go in your emergency department. And I just created, I would usually do 1 to 2 a year on various topics to get a clear picture of what my staff was looking for. All right, so going back, so interventions, when we're looking at actual interventions, these usually fall into about 4 categories. So we have policies and protocols, education, EHR, optimization, and then resources. So policy should clearly define expectations for vital signs, and that should be made very clear. We don't want to be generalized, and we want to be clear with what we should be doing. So are we taking vital signs every 4 hours? What patients are we taking vital signs on every 4 hours? What patients are we taking vital signs on more frequently? And that should be based on patient condition. What are abnormal thresholds? And this is something that working with your physician and quality partners could be really helpful, where you help to establish abnormal thresholds with what is normal and what are our reassessment timelines, and then what are the escalation procedures. With that, I would also add in here, what are the provider notifications requirements as well related to abnormal vital signs. And so that should all be clearly detailed in a policy around pediatric vital signs. Education focuses on accurate measurement, recognition of abnormal vital signs, utilizing validated pain tools like Dr. Chibitazi talked about last week, appropriately escalating concerns. And if you're not comfortable escalating that concern, then going to a charge nurse or going to someone else to help you work through how you're going to escalate care and communicate the need for escalating care. Scenario-based exercises or simulations reinforce these skills. Those are great on skills days. You can give scenarios like, how would you handle this? Is this abnormal? How would you talk through someone with this? How would you report this to a provider if you had abnormal interventions, and how would you document it? Those are great, little 4-minute exercises you can do, but it's that memory that is so important, and making sure people feel comfortable with escalating care and provider notifications. And then EHRs, we've seen a lot of optimization where EHRs can actually provide alerts for abnormal vitals. They can also report, vitals haven't been based on this patient, vitals haven't been taken in a certain amount of time. That can also flag on the EHR as well. You can streamline documentation and support trending for early detection and deterioration. And I think that's the most important piece for pediatric patients, is now that we have these monitors that pull vital signs right into an EMR, are we actually going in and looking at them, and are we actually trending them? And I think that's sometimes the missing piece, is we see them in the actual EMR, but we're not trending them, and we're not seeing the changes over time that's really cueing us in that this patient is starting to deteriorate. And then we also want to make sure we have resources, and that includes child size equipment, reference charts like we've talked about, any type of visual aids, pocket cards that support the staff and family in real time. I cannot stress how important it is to have those readily available for staff when they're taking vital signs on pediatric patients. Next slide. All right, so reassessment of abnormal vital signs should occur promptly per policy, but it can't happen if we didn't take a full set of vital signs in the first place, right? So when we have a full set of vital signs and we have some abnormalities, we need to make sure we are reassessing that promptly as defined by that policy that I just talked about in the last slide. Escalation protocols also should be clearly specified to notify who, when, and by what method. I will tell you there's a lot of, the text messaging that goes on now with all the different technology. I think we have to be careful to make sure that when we are doing provider notifications, that those text messages are also included in the medical record. So if they're not in the medical record, that can be hard to quantify at a later time if there was a poor outcome for a patient, where it looks like the nurse may have not fully notified the provider that there was an abnormal vital signs. And with that, I will also say, I know in my facility that I worked out, one of the things that when we went to a different EMR, one of the things we didn't know, the physicians couldn't see vital signs initially. And so, they had a very different screen than we did as nurses. And so that was one thing that we worked on very quickly, was making sure the physicians also saw the vital signs. They saw the red alerts when they went up, so they were aware. We still had to notify, in our nursing documentation, but that was a huge kind of shift. So they're seeing the vital signs as well. So those EHR flags, very helpful, can quickly identify patients with vital signs out of range, and you can, work with your providers on what the next steps are related to that. The family-centered strategies for reassessment, we just want to keep caregivers informed, and it can be, again, like I said earlier, a very stressful time for them. So when we're coming back in and reassessing, or we're doing vital signs frequently, especially when we're talking about, I always think about like night shift and the ED, kids are tired, parents are tired, their kids have been sick for days, and now we're coming in and constantly doing the blood pressures, just to check and stuff. And so it's really explaining to the families why we're doing this, and helping them to understand it, and be our team members too, to help us with these kids, because we want to reduce stress during vital sign checks and keep everybody comfortable. So we need to make sure that we are talking with the family so they can help support that as well. And then finally, we want to reinforce knowledge continuously through feedback from audits. I talked about earlier, simulation exercises, and then those quick reference tools. So together, these strategies help ensure abnormal vital signs are recognized early, addressed promptly, and documented accurately to improve safety and outcomes for pediatric patients. Hand that over to you, Kasey.
Thank you. So now that we've talked through our SMART aim or our goal and some ideas that might help us reach it, I want to introduce the framework that helps us actually test these ideas in a structured and manageable way. That's the PDSA cycle. PDSA stands for Plan, Do, Study, Act. And what's helpful about this approach is that it lets us start small. You're not changing the entire emergency department at once. Instead, you can test one change on a small scale. That might be one shift, one staff member, or one team, just to see how it works in real life. During that test, you monitor what's working well and what's getting in the way. By continuing to enter data into NPRQI throughout the cycle, you can monitor your performance, and this data will help you illustrate whether your efforts are actually helping your patients and making your workflow smoother. If you observe improvement, you can build on it and slowly expand the change to more shifts or eventually the entire ED. PDSA cycles help us try changes in a safe, low-pressure way, learn quickly, and spread what works, all while keeping the work grounded in real-time data. It means it's meant to support you, not add complexity to the process of improvement. As you start implementing a PDSA cycle, it's helpful to have tools to keep track of the work you're doing and see whether your changes are actually making a difference. On this slide, I want to highlight a couple of key tools that will help you stay organized and see your progress over time. The first tool is our Quality Improvement Intervention Tracker. This is a log where you can record each change you test, what that intervention was, and when you implemented it. Think of it as a running list of things you've tried throughout different PDSA cycles. It keeps everything in one place so you don't have to rely on memory or guesswork later. Secondly, you have access to that graphical view within NPRQI. As you input patient encounters, you'll be able to look at this view and actually see how your performance changed over time. This is where the value comes in, when you can line up your timeline of interventions with the NPRQI data and pinpoint which changes led to the biggest improvement. This makes it much easier to understand what's working, what needs tweaking, and what's worth spreading to more shifts or your entire emergency department. These tools make the PDSA process easier, more organized, and more meaningful by helping you connect your daily work to real results. You don't have to remember every change you tried. The tracker and NPRQI are working together to show the story of your improvement efforts. And as we look ahead, I want to emphasize that the PDSA cycle isn't something you do just once and check it off the list. It is an iterative practice, meaning we continue to repeat it and learn from it, and you get better over time. You taking what you've learned from the first cycle and deciding what to try next, you continue to monitor your progress, watch how your performance shifts, and using that information, you can guide the next set of changes. If a change worked well, you can build on it. If it didn't have the impact you expected, you can revise it and try something different. That's the whole purpose of the PDSA cycle, those small tests, quick learning, and constant refinement. And remember, as you learn, it's perfectly okay to revisit and adjust your SMART aim or your goal. As your goal should evolve as your understanding grows and we learn what's truly driving improvement within your environment. Each cycle moves you closer to a more reliable process and better outcomes for your patients. I'm now going to have us shift gears a bit and I'll hand things back to Robin, who help us review some additional considerations to keep in mind when managing pediatric abnormal vital signs.
Thanks, Kasey. Next slide. All right, so just a couple of things to, as before we go into the discussion part of this, just to kind of think in your mind, vital signs should travel with the child through every step of their ED journey, right? So when a child arrives, whether they come in through the front or the back of the house, we start with a complete baseline set of vital signs. So that's the first snapshot that tells us where this child is at physiologically before we do anything else. As the workup unfolds and interventions begin, vital signs must be rechecked intentionally. There are feedback loop telling us where the child is at. Are they improving? Are they unchanged? Or are they quietly getting worse? Any abnormal vital sign is a call to action. So we really want to reassess the patient, intervene as needed, notify the provider when appropriate, and document the response. Because when we ignore those abnormal vital signs, we break that safety chain for this patient. And then finally, vital signs, like I said earlier, help us to really guide disposition. So age-appropriate, physiological, normal vital signs support safe discharge, while persistent abnormalities justify an admission, escalation, or transfer. At my prior facility, what we did was a pause. If we had a patient that we were dispositioning, whether transfer, inpatient, or discharge to home, if we had an abnormal set of vital signs, we had to make a huddle with the provider and the provider would actually come into the room, talk with the family and the patient if they were able to talk. We would talk as a group about the plan. And I think that was always such a safety piece that worked very, very well for us and caught a lot of patients that potentially could have had a return visit to the ED where they just needed some more specialized care at that point in time. So most patients arrive to the emergency department through triage. And so though how triage looks can vary. So we have screener nurses to a dedicated triage nurse, director room workflows, ambulance arrivals. Regardless of that pathway, that initial patient content is the moment for that baseline assessment. It's so important. At that first point of contact, we should obtain that full set of vital signs, establishing where the child is at before that care actually begins. Most U.S. emergency departments use the ESI system. You guys can go in the chat and put how many are using ESI. If you don't have a standardized triage system, that is something you should also be looking into. And then it's important to remember that vital signs are a required component of ESI decision making. And I think, and there isn't a caveat for not for children, right? It is a required component of ESI that we get vital signs for kids. High risk vital signs should immediately influence ESI assignment and may require escalation. So that's why we have those high-risk vital signs on the ESI protocol as well. So using vital signs consistently at triage ensures the right care reaches the right child at the right time. Next slide, Kasey. So in pediatrics, one set of vital signs may not be enough. So we really need to make sure we're reassessing at regular intervals and after any intervention to evaluate the child's response to care. That trending is what matters most. They allow us to detect those subtle changes in the patient before they go into significant deterioration. And when vital signs fall outside of age-appropriate ranges or trends, we need to have that prompt escalation of care. So that includes immediate reassessment, timely provider notification, and engagement of broader care team as needed. So that escalation of care piece is so important, and having that voice to escalate care for some can be very difficult. And so again, making sure you're connecting with someone if you're not comfortable escalating care. And then the documentation piece really closes that loop, recording vital signs, your interventions, responses to the interventions, notifications, ensures continuity of care, and supports safe, informed decision-making for the patients. Next slide. And then lastly, just a couple of key considerations that I just want to go over before we open this up to questions. Vital signs obtained at presentation establish the baseline for decision-making only. In pediatrics, early abnormalities are often very subtle, so repeat measurements and trending over time are essential. We want to make sure abnormal vital signs trigger that timely age-appropriate interventions, followed by reassessment to confirm the child is responding as expected. Lack of improvement or worsening trends require immediate escalation. Reliable systems to support reliable care. So teams need ready access to pediatric appropriate equipment, age-based reference ranges, and EMR supports, such as alerts, reminders, standardized documentation to ensure vital signs consistently drive reassessment, escalation, and team communication. So as we move into this next part of the presentation, what strategies are you interested in to improve performance around abnormal vital signs? All right, so
Robin, we have a couple of questions in the chat if we want to start with those.
I lost my chat halfway through. So
I think I saved where we were at. So the last question I have was, what particular resources do you recommend that are available to staff?
I think it depends on where they're located. Badge buddies are great, but I think sometimes we all carry so many badge buddies, it can get cumbersome. So having posters, I'm a big fan of having things in rooms. So having a laminated set of like what normal vital signs are, if you have the workstation on wheels or you have whiteboards, like you can put them on there. So they're quick references that you can see anywhere and everywhere. Also, the families can see them too, right? So I think that's helpful. Badge buddies, okay, great. As long as they're not weighting you down and you're actually looking at them during taking vital signs. And I would say those resources also can be used by our support staff as well, if they're the ones getting the vital signs on patients. So they can come up and tell you like, hey, this is out of range. And that should be also part of onboarding and annual competencies as well.
For that. And then someone just wanted to follow up. You shared a story about a hospital you're working in where the EHR wasn't sharing the vital signs with the providers. Do you recall what that system was?
That was Cerner. And I will say it was back in the early, I'm going to date myself, like early 2000s. So it was Cerner, and it was just the way that you can customize a lot of things. And the way that the physician's page had been set up in the build, it just did not include vital signs. And so and there was a situation with a patient, and that's how it all came. The nurses didn't know what the physician saw, physicians didn't know what the nurses saw. So, and that was where we identified a significant gap, and we addressed it, and our IT department got it fixed up for us.
Thank you. And what way do you find most helpful to provide audit feedback to nurses? Maybe through email or other methods?
I think it depends. Two things. I think it depends on the person who you are. Is it how to do the audits or just to give feedback? Sorry.
Kendra, you can come off mute and expand a little bit, but the question reads as feedback from the audit.
I think it's always, I come from a place of like, nothing should be punitive. I'm a very anti-punitive person. It's like, let's build people up and not wait to get the gotcha moment. Let's actually support people and build them up to be great clinicians. So I would always approach someone with like, hey, I was always very transparent on what audits and things that I was working on with people. So people knew that they were being audited, or that a process was being audited for QI. And so I would just come up like, hey, working on this, let's talk about this. And where are you seeing barriers? And I would always come back to like, where are you seeing barriers? Because it puts the impetus that like the organization has messed up, right? Not that the person has messed up. It's like, okay, so where are your barriers? Where are we struggling? How can I help support you? Is the always approach that I've always taken. And then usually because people will automatically become defensive in a lot of cases. And so when we're defensive, we're not really getting the message, right? We're so worried about what are we going to get in trouble, things like that. And that shouldn't be that shouldn't be our custom and practice of how we treat each other in a professional environment. So really just building them up and talking to them about that.
think that's a great point. You're performing quality improvement on the process, not on a person's work.
Absolutely.
All right. For trending vital signs, are teens using pediatric early warning scores for early recognition of deterioration? Looks like some folks who are on the calls are sharing that they are using those early recognition systems. I don't know if you have any experience with that.
Yeah, I mean, we had looked at it at one point in time. I think Pews is, I mean, there's a ED version of Pews that a group has put out that I think more characterizes the patient in the emergency department. Again, like Pews, it gives you scoring, but if you have a truly sick kid, you already know that information, really. So it's kind of good for the lower acuity patients, but vital signs can oftentimes give you that same information. So I wouldn't say don't use it, but there is a ED version of Pews that might fit a little bit better than your standard Pews because again, Pews was made for inpatient settings, not ED settings.
Question from Gregory. Do you standardize the way in which you obtain vital signs? They're rectal versus temporal temperatures, clothing and triage when obtaining initial weights, reassessing weights with difficult presentation, injury versus wheelchair, or layers of clothing and blood pressure?
So yes, standardizing. You guys ask such good questions. Yes, standardizing in the way that, yes, we get a full set of vital signs, right? So standardize that way. How I obtain them, I'm going to do least scary first, right? So I'm going to I'll date myself again, like ET, like if I need to get a pulse ox, I'll put the pulse ox probe on, and it's a sticker and we make it fun and our finger lights up and that's really cool. So I get that after I'm doing that and they're admiring their finger, I'm checking their respiratory rate with an actual stethoscope. And like listening to their breath sounds, like I'm doing that at one time for my assessment piece, but I'm also getting their respiratory rate. Blood pressure, I will put the cuff on, but I won't do it for a bit. I'm going to give the kid a minute to get comfortable with it. Sometimes I will let them hold a blood pressure cuff of a different size, play with the Velcro. You've got to make it fun for kids. And if you make it fun, they will usually participate. So it depends on the kid. The last thing I usually will get, in all honesty, is weight, especially in the younger toddler groups. The scale scares them to death. If you're asking them to get on a full-size scale. So I usually save the weight for last, actually, unless it's a critical patient that I'm sending straight to the back. But so the standardization is getting it all. The order, I let the patient kind of guide what I'm going to do for that. Rectal versus temporal. In smaller infants, and policies are going to be different on this. At least that used to be under 2 years of age. We went to under 2 months of age for rectal temperatures, and that's what our provider group was comfortable with. But we were still getting rectal temperatures in our neonatal group specifically. And again, we want to make sure we're checking for hypothermia and hyperthermia in that group as well. But that is something we did. Clothing and triage, I am not taking a kid's clothes off in triage. That is just, especially if you have an open triage space, I am not taking a kid's clothes off in an open space. We can get a pretty solid weight if we're putting them on the scale, on a baby scale, we're going to get that weight, and it's not going to be off by that much. I would remove the clothing that we could remove in the shoes. But yeah, we're just going to have them get on the scale and get a weight for them. Reassessing weights with difficult presentation. Well, we have weight estimation tools that we can use to get weights if it's a difficult presentation. So just like if they came in via EMS, if I had a patient fully accessorized in a wheelchair, neurologically devastated, trach, G-tube, vent, the whole 9 yards, I am going to have to get a weight estimation for that patient, or get a scale, a bed scale for that patient as well. And layers of clothing for BP. So I would get down to the lowest level that I possibly can. I don't want to put it over a coat or sweatshirt or jacket if I can get that arm out. And sometimes it's just as easy as telling a kid, I would love to see your muscles. Like, let me see your muscles. And they'll be like, oh yeah, let me show you, and so then they'll take the coat off without fighting with you. So it's really, again, just making it a game, letting them push the buttons. That's another big one, is just letting, they can put the blood pressure cuff on you, you can put it on them, but let them push the button. And that often can just make them so happy. Not so much the teenagers, but the younger ones.
Leads right into the next question of any suggestions for getting accurate blood pressures in infants and toddlers, stating that's often a barrier they hear in their ED.
This is one of my favorite conversations to have with when I work with some hospitals, because they'll always be like, oh, it's so hard. And I'm like, you cannot tell me that 85-year-old woman with crazy tremors is also easy to get a blood pressure on, right? We all have the patient populations across the age span can be hard to get vital signs on. And so we need to try. And I think that's important, but kind of what hospitals have gone to because of I think I can't say for sure, but primarily I think related to staff is because it's hard to do. But sometimes that's just because equipment barriers and they're not comfortable with actually doing it. So I think if we identify the barriers, we give people support, it actually will help them actually do vital signs better. The one thing that we don't want to start saying is, oh, any patient under 5 should not get vital signs or should not get a blood pressure. They can get everything else, but not the blood pressure, because that blood pressure for kids when that blood pressure is low, that patient is seriously decompensating because they will have that tachycardia first. The blood pressure is second to go. So blood pressure is very important. And as we see a lot of people using the emergency department for their primary care, kids do have disease processes that can cause significant hypertension and other problems. And so we do need to make sure we are checking vital signs in these kids. Even young kids can have, one of my very first patients, primary patients, she had a chronic kidney disease, and her blood pressure, she was less than a year old, would run over 200 at times, systolic. So, I mean, these kids can have, and she would look completely normal at the time. So it's important that we're checking a full set of vital signs on these kids. And yes, infants and toddlers can, I would say toddlers are going to be your worst, but just make it fun. And sometimes it's just making it fun will make all the difference with that. And then I will also say the one thing too, from a triage perspective, is talking to the caregiver, because kids, if you walk right up onto them and start with all this equipment, it's really, really scary to them. So having the equipment in your hand, be like, oh, do you want to hold this? And then also talking to the caregiver, because that shows the child that this person is okay, right? That they're talking to my mom, or they're talking to my dad or my grandma and grandpa. This person's okay. Just walking up on them can actually give them, that stranger danger situation.
Right. Shifting gears to weighing and recording in kilograms. Question about when considering weighing kilograms, what do you recommend when your equipment weighs in pounds as well? And considerations when your EMR records in both.
Okay, so this is a big one, especially for general EDs. Many EDs across the US have moved completely to kilogram weights for adults for their entire span, just because of the safety around that. So I am seeing in the hospitals that I have worked with or have done some support stuff with, I am seeing that a lot of those have moved just to kilos. And then they'll have like a sign usually in their triage or in some of the rooms where that conversion of like what the patient weigh actually in pounds. But I think having the option to weigh in pounds, I think, is incredibly dangerous for kids specifically. And if you only, average hospital sees about 10 pediatric patients a day, general ED. So I think if you're limiting it just to say, we're gonna convert it just for those kids, I think that could be a problem with your practice. And if someone makes a mistake, that could seriously impact the child if we were giving medications. And so I'm a huge advocate of locking scales in kilograms only. That being said, that's usually a conversation with your materials management. In a lot of, out here in Los Angeles, a lot of the hospitals, a few years ago, we went in and looked at our hospitals that were not pediatric recognized. And we found a lot of those individuals were weighing in pounds, and they did have a number of errors around medication dosing related to that we worked with them on. But one of the things that they had been told was that especially at one facility, was that their materials management couldn't change it into kilos. And so we actually went down and talked to the facilities group and said, hey, you can lock this, because I had the same scale at my facility, so I knew they could lock it in that. And so sometimes it's just talking to your IT department or your facilities or materials management group, and they can actually lock it for you on the back end. So highly, I just going to an all kilogram weight is just what we're starting to see in a lot of facilities across the country now for all patients.
Yet a number of other participants share some of the successes they've had in making some of those changes or locking their scales. We'll add there's also an NPRQI quality measure. It's the percentage of pediatric patients whose weight was recorded or weighed and recorded in kilograms only. So some of the participants from our last collaborative were able to utilize their performance on that measure to go back to their hospital administration and sort of indicate, we're not performing well in this, and these are the barriers in our system, and here's how we would like to improve that. So it's a good data point for you to be able to share with your leadership. All right, I have a question for you, Robin, about the Broslow tapes being recalled. I don't know if you have any updated insight or new information on that to share with the group.
So again, just as Lisa put in the chat, Joint Commission, we're going back to the 2019 tapes if you have them. There are other proprietary groups that do have similar products to the tapes. And so some of them are on back order, but there are other groups out there. If you have a formulary, and I'm hopefully getting a copy of one in the next day or two, that we might be able to put on the site, but it's, if you can go back to the 2019, go use your 2019 until the fixes are updated. I can only imagine in facilities how this has just been such a hardship on so many people. So I would, get weights whenever you can. So if you need to get an extra scale or bring a scale to the back, if you have a critical patient, use your infant warmers if they have built-in scales, to at least to get an accurate weight in the interim while you're doing this. And if you have a formulary that, a lot of people have the Broslow sets, and they create their own formulary where it's like by this color code, these are the sizes, these are the dosing. They actually have that in page form, not just on the actual Broslow tape. So if you have that, or you can connect with a hospital in your network or in your region to see if they have something similar, and then just run it by your pharmacy for them to review it and approve it. That's something else you can use as well. But you may, again, just having scales closer and maybe not just in triage for infants, but like in other areas can help during this time to get actual weights on patients.
Well, there's a follow-up to, should we have the EMR only display in kilograms? Well, sure, that is the gold standard. That's what we'd like to see. It just helps eliminate any possibility of error. I know some institutions who have made changes to where the print off for the patient includes the conversion to pounds for the family members, but on internal workspaces, it's in kilograms only.
Yeah. And so, I mean, if you think, if you're looking, I mean, especially if like you have kilos and pounds right next to each other, I mean, just you accidentally look at the wrong thing, and that could just be a significant issue for a pediatric patient. So I think that's where the safety piece comes in, is if you are going to put pounds somewhere, move it away from where the kilograms part is. And so you're not just quickly looking at something and checking a weight, just potential poor outcome for a child.
And so as you're considering, building out your team at your ED to help you with your quality improvement project, if some of these ideas you have are related to your EHR, you might want to consider reaching out to your health informaticist at your site or other contacts, so you can have a point of contact who can help support some of those EMR updates. Thing to consider. All right, I think I've captured all of the questions in the chat. If I've missed one, feel free to post it again and we'll get to it. But I did want to share some resources we have available for you all. A number of resources to help support you as you begin your quality improvement work. You can locate our abnormal vital signs reassessment intervention bundle, which includes a lot of information shared today, overviews of why you might want to focus on this area of focus, as well as some of those change strategies. They are under our resources page. Great place to find all our intervention bundles, as well as some quality improvement tools as you're getting started. I also hope that you've been able to locate our collaborative hub and that that's been helpful to you all. We anticipate this being a great resource moving forward. I saw in the chat there were some questions of, hey, where can I find a badge buddy? Or what about some posters for our triage areas? Within that collaborative hub, there's a place for you to submit your resources so that you can begin sharing them with one another and modifying them for your institution. So if you have some of those in place already, love to start seeing those come into the library and sharing among participants of the collaborative. So if you have any questions about how to access the hub or how to use the library, please email us and we can get use some steps in place to get that going. And then we also have office hours, so opportunities for one-on-one meetings. These are 20-minute sessions. The registration link is also under the collaborative hub. So lots of great things there for you. And then all things NPRQI can be found on the NPRQI website as well. And we'll continue to have monthly collaborative sessions on the third Tuesday of the month at 11 a.m. Central. Again, those one-on-one opportunities. I want to go ahead and jump ahead to our CE slide for you, but if you haven't already, please make sure your first and last name is in the chat so we can get this CE out to you after you've completed the survey. And thank you all for joining today's session. If you do have any additional questions, we'll be on for another minute or two. And see another question about recordings from previous sessions. Yes, all sessions are recorded and made available under the collaborative sessions page. Thank you all, and we hope to see you at our additional focus area sessions. We'll be hosting another one next Thursday on head trauma.